A 68-year-old man comes to the office due to worsening back pain. The patient has a history of severe lumbar degenerative disc disease that limits his daily activities. He declined surgery and treatment with non-pharmacologic interventions, and non-opioid analgesics have not adequately controlled the pain. Okay. Patient began taking long-acting oxycodone. Okay, this is an opioid. 5 with good pain control. Okay, over the past 2 months, he reports progressive worsening of the pain despite a modest increase in dose. Okay, even after the increase. Also takes acetaminophen or paracetamol for breakthrough pain and an osmotic laxative, maybe lactulose. Physical examination shows lower paraspinous tenderness but no lower extremity neurologic deficits. Spine imaging study shows no significant changes. Which of the following is most likely for decreased analgesic efficacy? This patient has basically become tolerant and has developed tolerance. Types to be discussed. Chronic opioid therapy this patient is receiving for low back pain due to lumbar osteoarthritis, which is a diagnosis. Okay. Because increase, no new structural explanation, like everything is normal, right, in the imaging studies. So a distinction should be present between pharmacokinetic tolerance, ADME, absorption, distribution, metabolism or excretion, or a pharmacodynamic kind of tolerance. The plasma level of the active drug is unchanged. However, the action of the drug on target cells is blunted due to receptor downregulation. There is a difference between receptor desensitization and downregulation. Desensitization is acute, whereas downregulation is chronic. Decreased intracellular signaling. In both cases, tolerance can be innate or acquired. Let us have a full-blown approach to understand what are the mechanisms of tolerance with examples. First and foremost, I'll be discussing with you acquired pharmacokinetic tolerance. Decreased absorption, increased distribution ADME, or increased metabolism and excretion. The case of enzyme induction. Or there can be decreased plasma drug concentration. Examples here, rifampicin accelerates the metabolism of warfarin. Carbamazepine induces its own metabolism after repeated dosing, which can be remembered by enzyme inducers GPRA self-1. Griseofulvin, antifungal, griseofulvin, phenytoin, rifampicin, smoking, carbamazepine, phenobarbital. Then the second one which we are discussing here is acquired pharmacodynamic. Decreased cellular response to the drug. Receptor downregulation. Unchanged plasma drug concentration relative to naive state. This is seen in the case of chronic opioid use. As in the question, there is decreased expression and responsivity of mu opioid receptor symptom, mu, kappa, delta, or these are the opioid receptors. And another example is frequent albuterol rescue inhaler. If you take more of bronchodilators like salbutamol, there is decreased expression of beta 2 receptors. This is also acquired pharmacodynamic. Then talking about the third, which is innate tolerance. This can be either genetic due to polymorphisms, then it can be epigenetic due to DNA methylation differences. This leads to pharmacokinetic or pharmacodynamic, and this tolerance is apparent from the first dose. Example, slow metabolizer of CYP2C19 allele, decreased clopidogrel activation. So if clopidogrel activation will be less, obviously there will be decreased antiplatelet effect because clopidogrel is not activated sufficiently. Mona darling, morphine, oxygen, nitrate, aspirin. Myocardial infarction. We give aspirin with clopidogrel also in heart attacks. Then another important slow metabolizer, CYP2D6 allele, decreased codeine conversion to morphine. And as of all of you know, अभी तक till date हमारे पास morphine से ज़्यादा powerful analgesic market में है नहीं. So decrease analgesic effect. अभी कम morphine बन रहा है इसलिए. Last but not the least, behavioral or functional. This is the ability to compensate for drug-induced impairment through learning and practice, जैसे कि maintaining appearance and mannerisms to appear non-intoxicated at all. कोई लोग दारू पी के आ जाते हैं हमारे हॉस्पिटल में काम करने और लगता है बिल्कुल परफेक्टली फाइन है, उनको इसकी आदत हो चुकी है. Then innate tolerance due to genetic polymorphism. One by one. The patient experienced a good analgesic response. So analgesic response is good. This argues against the presence of innate. There is no innate tolerance because there is good analgesic response. Then acquired tolerance, I told you, decreased pharmacological response following prolonged drug exposure. Acquired pharmacodynamic tolerance is the primary form of chronic opioid tolerance characterized by downregulation and decreased responsivity of the opioid receptor symptoms. Decreased responsivity, GRK or beta arrestin phosphorylation. This is a mechanism, you should know this. GRK or beta arrestin phosphorylation of mu opioid receptor. Then pharmacodynamic tolerance due to overexpression of delta and kappa opioid receptor. This is wrong because the kappa and delta opioid receptors, they basically go and bind to endogenous opioid like neuropeptides produced in the body, like delta, kappa and delta. So kappa binds to dynorphin and delta receptor binds to enkephalin to mediate analgesia. Like mu receptors, they are also downregulated by chronic opioid administration, contributing further to acquired pharmacodynamic tolerance. Then option D, a pharmacokinetic tolerance with decreased rate of drug excretion, and acquired pharmacokinetic tolerance. Altered ADME results in lower plasma drug levels. Higher rate of metabolism can accelerate an activation or elimination of many medications. Important ones are methadone and carbamazepine. However, lower rates of excretion here due to renal or hepatic insufficiency, which are the most common routes of elimination, would raise the plasma drug concentration, leading to overdose rather than tolerance. Obviously, if there is decrease, then there can be an overdose. Then, last but not the least, pharmacokinetic tolerance due to drug partitioning to the adipose compartment. And this is also wrong because adiposity or increased obesity can lead to pharmacokinetic tolerance by raising the apparent volume of distribution, thereby lowering the plasma drug concentration. However, equilibration between plasma and extravascular compartments is complete within 5 drug half-lives. And he has been taking this for so much of time, occurring long before this patient's development of tolerance after 3 months. 3 months furthermore. Now this is done within 5 drug half-lives. So that is why we are ruling out this option. Furthermore, adipose partitioning is a concern for highly lipophilic drugs. Adipose partitioning Highly lipophilic drug is fentanyl. This is a highly lipophilic. Oxycodone is not lipophilic.